I'm Dr Jam Kothari.
And I'm Dr Sally Moore. And this is a Myeloma Minutes, a podcast for people affected by myeloma, patients, friends and family. Welcome to another edition of the Myeloma Minutes. I'm here, obviously, with Jam, who's our co-host, and we've got a special guest today. But before we introduce our special guest, Jam, what's new? Good week. I've seen a little bit of you. We've bumped into each other at a meeting. How have you been?
Yeah, no, Sally, it's been nice to see you in person this week, not just on the end of a screen. We've had some great conversations with some blood charities over the last few days, and it's going to be really, really exciting, hopefully collaborating with them over the next few months. And we will be hearing from all of them, hopefully, and hearing about what they do for our patients. The other really interesting thing, Sally, we were looking at is you start a podcast and you don't realise like how much data that you can get about your listeners and where they're from.
For sure.
So we know, Sally, so tell us some of the countries that people are listening.
Well, yeah, so let's give a shout out to our international friends and colleagues. So hello to everyone in the States, particularly our Alaskan fraternity. Lovely to have you listening. Great for all our European colleagues. Yeah, lovely. Stay with us. Please feedback wherever you are. And actually, please feedback in whichever language is your natural language. Jam and I will do our best to translate and see what we come up with. But yeah, we've got listeners from all over the world, Australia, New Zealand, Canada, Europe, Israel, Russia. I mean, the list is endless. So we are absolutely delighted. Spread the word, guys. It's so great to have you with us. And please do remember to feedback as well. So welcome.
Welcome. So I'm now very happy to announce our guest for today. So today's pod is all about scans and imaging in myeloma. As we know, bone disease and damage to the bones, sadly, is a central component to what happens in myeloma. And it makes imaging and understanding the different types of scans that can be done a really central part of the whole treatment of myeloma. So I'm very happy to introduce Dr Shaheel Bhuva, who is a consultant radiologist based in Oxford. So I've worked with Shaheel for over 10 years now. We both became consultants around the same time. Shaheel is an expert in cross-sectional imaging or X-rays for cancer with an emphasis on PET-CT, but he has knowledge of all the really important and key, what we call modalities, different types of scans that are important for looking after our patients. And we're going to go through a lot of this today. So Shaheel, welcome.
Thank you both. It's a real pleasure to be on. And I'm a big fan of your pod. I think you speak with expertise and compassion. And
yes, keep reading the script.
I'm sure
keep reading the script.
That lots of
flattery work, Shaheel.
Lots of patients and their families are really benefiting. Also, you reach Azerbaijan. So your international appeal is
Azerbaijan.
Is
I've always wanted to go to Baku to meet our listeners. So thank you.
That's very kind. Thank you.
Tell us a bit about your job and as a radiologist, what you do and how it helps our patients.
I'm a radiologist, so I'm a medically trained doctor who specialises in imaging. And that can be imaging from ultrasound to X-rays through to the more complex types of scans that patients will have. We play an important role really in working with yourselves and other members of the multidisciplinary team so that we can provide accurate information about where the patient might be and help piece together all the puzzles that might help make up that diagnosis and what would be the best management plan, how patients might have responded to their treatment. So that's where our key role is. We're kind of a doctor's doctor. So we don't often interact with patients up front, especially not myeloma patients, although in some cases we would if they have an ultrasound scan or if they have a procedure such as like a cement vertebroplasty. So these are procedures that myeloma patients can have where they would meet a radiologist.
Sal, just to give a little bit of context before we talk about the different types of scans that Shaheel looks at and reports, why are scans so important when looking after patients with myeloma?
Wow. I mean, we spoke about this on previous pods, but we can't sort of reiterate it enough, really. They give us crucial information as to the activity of the myeloma. Also, it's really important to remember, and Shaheel, I'm sure you'll speak to this, that not everybody with myeloma suffers with bone problems, but we really need to know if that's the case or not. and to monitor the tempo of disease. So ultimately, when someone is diagnosed with myeloma, to first of all consider if they need treatment, and that speaks to the previous podcast we did on smouldering myeloma, but also are they responding to treatment, or if the disease looks like it's re-emerging, do we need to restart treatment soon to keep their bones healthy and therefore their body healthy, and minimise complications from the disease. So what you do, Shaheel, I mean, you know this because you sit in our meetings, is so vital. Because yes, you might be the doctor's sort of like sit in the background a little bit, but as far as we're concerned, you are centre stage to help us with our decision making. So thank you for all that you do.
Of course.
As we said, I think on the second pod, so sometimes, unfortunately, there is an imbalance between bone buildup and bone breakdown, and you get holes in the bones, and they can lead to fractures. So an array of the scans that are done are to look at variations on those themes. And one other important thing to mention is that myeloma, unfortunately, sometimes can go outside the bones, and there are more advanced scans that give us a lot of information about whether myeloma may have gone, for example, to the liver or another organ. So we'll say to a patient almost the first time we see them, you're going to need a scan. And Shaheel, what's the journey for a patient when it means that they need to go and have a scan, go to another part of the hospital? How does it work?
Just to reiterate one of the things you said, I think one of the features that we really can help define is the amount of bone involvement or the amount of damage that has happened to the bones. And so in the first instance, patients may have what's called a skeletal survey, which is a set of x-rays performed on a patient. And this is still performed quite widely across the world. And these take about 35 to 40 minutes, where a patient will meet a radiographer, who's the technician, and be asked to be placed in certain key positions so that x-rays can be taken of those areas of the joints and the bones. So that's probably the most common, at least historically, the most common test that a patient would have. It comes with its pros and its cons, so it's widely available. It has a negligible radiation dose, which is sometimes a concern for patients, but it has what we call a low sensitivity. So the ability of these plain x-rays, which are like photographs of all the overlapping structures in the body, the ability to detect those small holes in bones is quite low. It's difficult to see them. And by the time patients have these holes that are evident on x-ray, often at least 50% of the bone has already been eroded or broken down. So they can be at a more advanced stage than detected by other modalities.
We get patients referred to us via lots of different routes. And it's not that infrequent that actually someone may have an x-ray done for another reason, and there might be a query about an abnormality within the bone that then brings them to our door to do the further investigations. I'm sure you've experienced that as well. And what we would call an incidental finding. You're doing a chest x-ray, for example, to check an infection's cleared, but what's that looking a bit dodgy on the ribs? I mean, I'm sure you've experienced that in your day-to-day practice as well.
Yes, I think we see that actually across all the various modalities of imaging patients, and can often diagnose a patient at an earlier stage because they've not yet presented perhaps with bone pain, or finding that incidental finding on an x-ray or on a CT can prompt having the workup of the blood tests that would help them down their pathway through your clinic.
So these simple x-rays, Shaheel, you can see holes in the bones, what we call lytic lesions, and you can see fractures. But just to pick you up on a point, some of those holes would only be seen when you've lost up to 50% of the actual integrity of the bone. And I think that is why, when more advanced techniques have become available, the general recommendation in more sort of advanced economies where they are able to do more advanced scans is that different scans are done if you are potentially considering a diagnosis of myeloma.
That's correct. So, myeloma starts as an abnormal sort of tumoral deposit within the bone marrow itself. And it's only when those abnormal plasma cell tumoral deposits erode the bone that it can be detected on x-ray. So what we tend to perform, certainly in the UK, would be that of a low dose CT scan, or a PET-CT scan or an MRI scan. Those would be the three broad categories that are performed. And to take, say, CT scan as the natural next step from a series of X-rays. So this is still based on sort of X-ray technology. So patients will be exposed to a small dose of radiation, but this scan can be performed in minutes, so 3 to 5 minutes rather than 45 minutes. And so if patients, say, have got pain in their joints, in their bones, it is far more tolerable. It provides a three-dimensional view of the skeleton, as well as information about the other organs in the body outside of the skeleton itself. So this allows detection of those small holes in the bone at an earlier stage. It's certainly a step up from what was the traditional skeletal survey.
Patients often ask me about CT and they say, is that the donut? So why do they say that?
Yeah, there's a lot of food analogies and food symbolism when it comes to radiology. And it's a donut because the patient will lie flat within what we call a gantry, which will surround the patient like a donut or a polo or a hoop.
Other mints are available, we should say. We have to say that, don't we?
The actual X-ray beam and the detectors that detect those X-rays rotate around the patient in like a spiral formation. So yeah, it's kind of like a donut, but it is a short procedure. The actual ring part of the machinery is quite narrow. And whereas in other scans like MRI scans, which I think we'll go on to talk about, we don't find that patients often feel any sense of claustrophobia or anxiety around the scan itself. It's performed really quickly.
The technology's come on so fast, hasn't it, Shaheel? And I think as it has evolved, and we'll work through all the different modalities, our understanding of myeloma bone disease has evolved as well. And it's wonderful that the two are now working kind of side by side, aren't they, to improve all of our understanding. So Shaheel, one of these great advances has been MRI scans, and they come with their own pros and cons. I guess something you've already referred to might be the sort of potential claustrophobia element, but there are significant gains from MRI scans, aren't they, particularly in the context of myeloma bone disease? And I wonder, could you just talk us through those, please?
Yes, of course. So MRI is a technique that uses strong magnetic fields to generate an image of the bone, the soft tissues in the body. So it does not have the radiation exposure that CT would have. And its real benefit is having a closer look at the bone marrow itself, where those small tumours can be seen prior to forming that destructive process, those holes in the bones. So it allows detection and diagnosis at an earlier stage. The additional advantages would be, say, further down the line if patients have got fractures, because often patients with myeloma will have osteoporosis, which in itself is a benign process, so it's non-cancerous, but it can predispose a patient to developing compression fractures, for example. So MRI is a really helpful tool to differentiate those sort of benign causes of fractures and pain versus those fractures and pain that might be related to the underlying myeloma. I'd say in terms of further advantages and disadvantages, it doesn't actually allow visualization of the hard part of the bone, the actual cortex, as well as CT. And often these modalities are used to complement one another. Unfortunately, we're not quite at a stage where there is a single best study and that's it. But we often use the two in conjunction. And if there's a specific query or clinical problem that the patient is experiencing, we can use those two.
So is it possible to pick up bone disease and areas of potential trouble earlier on an MRI compared to a CT in most circumstances?
It certainly can be, for sure. And I think you've mentioned the SLIM criteria, the SLIM crab criteria in previous episodes. What's really helpful about the SLIM portion of that, or the M of SLIM, is that it's now integrated like MRI findings into the definition of myeloma. And so these are lesions or small tumours that are 2 or more, that are 5 millimeters in size, so really small in size itself. So that would allow an earlier detection.
And sometimes if we have a suspicion that there is bone disease brewing or it's under the surface and we've done a CT, we would naturally move to an MRI just to give us a bit of extra clarity on what might be lurking underneath. So to put it into sort of context, you can have a completely normal X-ray. Even a CT might be completely normal and not show any obvious areas of damage, or what we call, you can't see the focal lesions, or lytic lesions, which essentially means the holes that you see in the bones that can develop into fractures. But you may do an MRI and then all of a sudden you're getting much closer to the action, as it were, and you see the disease evolving.
I think that's a great way to think of it. And certainly with whole body MRI techniques, which are the more advanced techniques coming through, which look at the diffusion and the movement of water molecules, or the effect of magnets on water molecules, and the amount of fat within the bone marrow, we're able to detect those earliest changes, especially in your patients who might have smoldering myeloma with high risk genetics. So they're just in that middle ground and at risk of advancing into symptomatic myeloma. These patients can be identified at an earlier stage.
And Shaheel, could I bring in an example? I wonder if you agree this is a useful example of how the different modes of imaging you've spoken about serve different purposes. So a good example might be someone comes to us with back pain and they have, let's say, smouldering myeloma, which we want to keep an eye on. And first of all, we might do a plain x-ray of their back, and that doesn't show much, but their pain's still there. So then we might want to do a CT scan or an MRI. Now, an MRI in the context of back pain and myeloma, what you might want to look at is actually, have they fractured something in their back, but also, is the spinal cord okay? But then we might then later also want to do a CT scan of their back to check the actual integrity of the bones, are the bones nice and stable. So I think from a patient's perspective, sometimes thinking, well, you've already looked at my back, why are you doing it again? And is there another reason? I think perhaps you very beautifully explained how the different types of scans can give us crucial, different information about the same part of the body sometimes.
Yeah, thanks. I mean, exactly. So if we think of the bone as containing the marrow as the soft tissue component and the outer casing is the harder cortex, MRI is better at looking at the marrow, and CT is better at looking and assessing the bone on the outside.
I think it's important to say at this point, different hospitals in different countries have different access to different sorts of scanners. Not everywhere might have a certain type of MRI. There are different sorts of protocols where scans are done in certain ways. So I think wherever you're listening, whatever scans you've had or have been planned clearly have been done on the basis of your doctors thinking, we need to understand what's happening, but they have to work within the limits of what scans can actually be done. And by using a combination of listening to what you're saying and using the scans that are available, hopefully the right information can be garnered. And even Sal, when we're sitting in clinic, if someone comes, I've got a new pain, I'm just not sure what it is, we can get a plain x-ray in a few minutes and get some very immediate information. But other scans will take longer to be done. So there is often an overlapping role for all these different sorts of scans.
Yeah, it's a part of the triage process almost, isn't it? You know, you might want to do a plain x-ray straight away because you know you can get it straight away, and just make sure there's nothing obvious that you need to sort out, and the other scans, if they're still needed, come later.
Yeah, and I think just to sort of big up our radiology posse here, I mean, you guys have a really tough job. I mean, back pain is so common, myeloma isn't. There are so many radiological causes of back pain, and myeloma can be hiding under the surface, and it can be very difficult to sort this all out sometimes.
Yeah, I mean, I'll just pick up on that, and especially in the population that may be more at risk of myeloma, the older population. Well, these are patients who typically have degenerative change and arthritis in the back. They may well have osteoporosis for other reasons. And so these are all conditions that can mimic back pain and account for back pain, even if the myeloma is coexistent.
Yeah, no, absolutely.
And there's another scan that we request frequently. And again, I think actually, Jam, to your point, you know, availability of these scans differ, even in the UK, don't they, in terms of what you do for one of the sort of baseline investigations, but what we frequently do, certainly where I work, because we have access, is a PET-CT scan. So that's different from an MRI, and it's different from a plain CT, isn't it, Shaheel? Again, tell us all about it.
So a PET-CT is a scan that uses the CT that patients may have already had, maybe for other reasons, but adds what we call a metabolic assessment. So if we just take that one step back, cancers are addicted to sugar, and they often are highly metabolic, which means that they will take up glucose, which is sugar, at a higher rate than other parts of the body. And we really capitalize on that property to perform a scan called a PET-CT. And so what a patient could expect if they had a PET-CT requested is that they would be given some instructions beforehand, which include some fasting instructions, because what we use is radio-labeled sugar. And so if the patient is having a normal meal as well as having the radio-labeled sugar in the department, this can obscure the appearances. So we want to try and optimize the patient.
Sorry, Shaheel, what does that mean, radio-labeled sugar?
So this is sugar that has a small radioactive component to it. And it's because of that radioactive component that we can generate images. So what we use is F18 FDG, that decays, which means that the amount of radioactivity drops off quite quickly. But they would have an infusion in the morning, say, and be asked to rest for 60 minutes or 90 minutes, depending on the protocol in the hospital they're at. And then after that resting period, they would then have a scan, again, similar to a CT scan, whereby the radio-labeled sugar is taken up by the tumor cells, as well as other parts of the body. And it's at that point, as the radioactive sugar decays by what we call positron emission, that generates an image that is created and so pinpoints where exactly the hot spots in the bones and elsewhere in the body are.
I mean, that's so clever. So you have a scan that not only gives you sort of the structural information, but it actually gives you information about what's happening biologically in different tissues. I mean, that's quite amazing.
And that's exactly what it is. It's sort of what we call hybrid or molecular imaging. I think we should just point out that the types of PET-CT that we do at the moment are good. They're not absolutely ideal, and there are some circumstances where an FDG PET-CT may not provide quite as much information as the hematologists and the doctors who are part of the MDT would ideally want for the patient. But the advancements, as you mentioned, Sally, are progressing at a very fast rate, and that includes in PET-CT and the types of these tracers that we use.
So, Shaheel, a really, really basic question, but what do you do with diabetic patients? They're people you shouldn't necessarily be sort of squirting sugar into their body. What's the get around there? Because actually that's a relatively common condition.
Yeah, absolutely. And so patients with diabetes would have a local protocol at their particular hospital, and it depends on the type of diabetes. So some patients have diet-controlled diabetes, some will be on oral medication such as metformin, and some patients will have injections such as insulin. And we really try and time their scan and their preparation before the scan to make sure that they're safe and that they don't go into a situation where their blood sugars are too low, and perform the scan when their blood sugar is at an ideal level. I just emphasize for patients who do have diabetes that you would get instruction from your local PET department exactly what to do, and that the patient's safety is the principal concern, and that we'd make sure that they are not in a state of low or high blood sugar, and similarly that they would take all their necessary painkillers beforehand.
No, thanks, Shaheel. So one of the big advantages of a PET-CT is that it covers the whole body, essentially, or as much of the body as you want covering. Are there any types of myeloma or specific indications in myeloma where a PET actually may give extra information?
Yeah, so there are a number of what we call indications or roles for PET-CT, and I guess the first would be in what we call staging. So a patient might have just a single site of myeloma or what we call a plasmacytoma, and the PET-CT could be performed in conjunction with other tests such as a bone marrow biopsy to confirm whether there is myeloma elsewhere in the body or whether it's just at that single site. And if that's confirmed it's at a single site, that would place the patient down a particular route of treatment. What we can otherwise identify is if the myeloma is more widespread with holes in the bones in other sites of the skeleton. And if that's the case, the anatomical, the structural information from the CT will be able to help allow us to determine if a patient might be at risk of a fracture. So, for example, if patients have a big hole in the side of the pelvis or in the hips, these are sites which are weight bearing and be at risk of fracture. So that's the second major role for PET-CT, as well as down the line once they might have treatment to see how they've responded to treatment. And finally, to assess if there is involvement outside of the skeleton, so if the liver or lymph nodes or anywhere else.
Thanks, Shaheel. Such a useful summary. I'm learning so much. We should chat more often. It's brilliant. Now, the patient experience of a CT or a PET-CT is a bit different from an MRI, isn't it? I mean, in fact, I was with somebody recently who had an MRI scan. I was sat outside the scanner and my word, I knew when this person was being scanned or not. What does it feel like to be there and having, talk us through the patient experience, please.
It can be an unusual and an experience that can be associated with some anxiety, completely understandably. I think that what would happen is that the patient would have a sort of questionnaire and some time with the technologist outside of the scanner, just to make sure that they understand exactly what to expect, that they don't have a pacemaker or any metallic implants which would preclude them from having an MRI scan.
Well, actually, just to interrupt you there, that's what happened. My friend had to take off all her jewellery. She wears quite a lot of jewellery, and it was there in my pockets while she was having a scan. So yes, you sort of, to remember, I guess, really, to all that metal business is quite important, isn't it?
Yeah, and I think maybe patients should try and go to the hospital for their scans in comfortable clothes, take off any unnecessary jewelry, especially necklaces, rings. If they're having an MRI, then all metallic jewelry. But even for the other scans, it's probably best to remove unnecessary jewelry, belt buckles, that sort of thing. And so once they've had that initial session just to make sure that they're safe to proceed, they would typically lie in the scanner itself, and the MRI scanner is a bit like a CT scanner. It's a donut, but this time has a slightly longer coverage. So in an MRI scanner, patients can experience claustrophobia because the donut shape of the machinery is a bit more elongated and covers a lot more of the body. And so I think if patients do know that they suffer from claustrophobia, this is something perhaps just to discuss with yourselves or their GP beforehand, if there are any measures that they can take to make the experience a bit more tolerable, recognizing that the information that's gathered from these scans is so vital to help them secure a diagnosis and move forward with their treatment.
I've had an MRI. It is a very interesting experience. I think two things for me I remember. One, the noise. It was very noisy. And to help the claustrophobia, they actually put in a mirror inside, which I actually found quite helpful, actually. And it did help. But, everyone has a slightly different experience of it.
And did they play music as well, Jam? Because sometimes they do that, don't they, Shaheel? Yeah. You have like headphones on to sort of take away the sound.
Yes, that's right. So you can have noise-cancelling headphones or some sort of gentle, soothing music, something to help the patient feel more comfortable. And the radiographers will be speaking to the patient throughout their scan as well. So these are all sort of small measures that are employed to try and make the experience more tolerable.
I think an important thing about scans, and people will be getting different scans at different stages of their myeloma journey, is that it is a crucial way, and we have touched on this, but we should expand on it a little bit more, is one of the ways in which we understand whether people are responding to treatment. Now, we have blood tests, which are part of that, and bone marrow tests. But Shaheel, could you tell us how we also integrate scans and scans at different time points and how they help us tell whether someone is responding to treatment?
The starting point would be the baseline at the point of diagnosis, and that really gives a picture of where the sites of disease or the holes in the bones are distributed throughout the skeleton or outside the skeleton where there might be other sites that are involved. And it also shows how brightly these areas glow or how hot they are, so that once a patient has had their initial treatment and are being reassessed, as you say, we can perform the scan in exactly the same way, but compare those different sites to see whether the brightness of the glow, or what we call the avidity, has reduced, and whether there are any other signs which we can see on the CT to support that there has been a response at those sites.
So I guess timing is really important, isn't it? Because you don't want to be sort of using any imaging modality too frequently, not least because it's a precious resource. But also our blood tests can tell us a lot. But I guess at crucial time points in terms of decision making, or if you've got a particular concern about someone's pain, for example, or their disease progressing, that's where we go in and order a scan. That's certainly what I do. Is that your approach, Jam, to sort of be quite targeted in terms of, first of all, the imaging that you choose, knowing actually, and you guys ask this all the time of us, Shaheel, don't you? When we request something, tell us all the information to make sure we're doing the right scan for the patient. And we need to think about that in clinic as well. Are we ordering the right test at the right time for the right person? And so, yeah, timing it right is vital. Is that what you do, Jam?
Absolutely. And a lot of the time, blood tests do give us good information about whether someone is responding to treatment. Sometimes we worry that the amount of new pain, for example, is not in keeping with how the blood seemed to be going. So that might be an indication to do a scan. And unfortunately, sometimes as people respond, they can actually develop fractures, what we call insufficiency fractures, from the volume of myeloma they have in their spine, for example. But as you say, Sally, it is a precious resource, and our radiologists are a precious resource. So doing the right scan at the right time very much allows us to integrate that into how the patient is feeling and combine that with blood test and bone marrow results to get an overall picture on how the patient is doing.
I wonder if I might just add to that using imaging like PET-CT has particular challenges in myeloma patients versus patients perhaps who've got other cancers. And that's because of the impact of chemotherapy on the marrow itself and the recovery process that the marrow will be undergoing. It becomes difficult to interpret. So as you say, the timing of the scans is absolutely crucial. That additional information just always helps us to be able to make the best interpretation we can at that time.
And that's where the MDTs are so crucial, actually, because when we might forget that crucial bit of information that you guys need, we then get together and explain what we perceive is going on and what the patient's told us. And then it's like the extra layer of information, which I think the MDT then assimilates to come up with hopefully the correct sort of diagnosis and treatment plan for that patient, which is why these get-togethers once a week are so vital, aren't they?
Absolutely. So we've got a few questions for you, Shaheel. I think questions that patients sometimes ask us and we don't know how to answer when it comes to specific things about scans. We'll see how you do. We'll mark you. And I think non-radiology clinicians should be better at answering these questions, because we often get asked about radiation exposure, right? Your exposure to radiation and what that means. Is it dangerous? Is an X-ray a small amount? Is a CT scan more? Someone told me if I get on a plane and fly to New York, that's the equivalent of 200 X-rays. There's all sorts of data and information around this. What's the general risk, Shaheel, and what should we be telling our patients?
Yeah, I think that's a really, really important point and something I've come across when I've had interactions with patients as well. I guess there are a few things to think about. Firstly, that often in myeloma patients and other patients with cancers, we're not screening them in the same way that we would for patients perhaps who have part of the breast screening program. So these are patients who are completely well. So the first thing to really think about is the risk benefit, that does the benefit of having the scan, the information that's gathered, potentially making a diagnosis at an earlier time point with the attendant benefits to the patient, is that worth having those scans and the associated radiation? The second thing would be, so who's at risk? Well, outside of the young pediatric population, the risk of developing a cancer as a result of radiation exposure really drops off. Children are, because their bodies are rapidly developing, the tissues are rapidly developing, at higher risk of injury from radiation from a scan. But in the adult population, this is really just not the case. And the third thing would be just to say that we are all subjected and exposed to radiation on a daily basis, like your patient who talked about being on a plane. Like, that's absolutely true. We have cosmic radiation that we're all exposed to. And some of the scans that are performed really are in proportion to the radiation that one would be subjected to in a year of just normal living. So I think these are the things to bear in mind. And the crucial bit would be that the real benefit to the patient from information from these scans. And because in hematology and myeloma, you're using other markers such as the protein levels, the blood tests, that these all help direct requesting and the use of imaging in a far more effective and targeted way.
Really useful. I mean, I used to live in Cornwall. I'm sure I lived on a lump of granite, and it didn't even cross my mind when I lived there, Shaheel. But that sort of emits radiation like goodness knows what, doesn't it? So it's all around us, isn't it? Everywhere we are.
I was wondering why you were glowing, Sal. I just thought you'd just been out in the sun. But
it's a joy of doing this podcast, Jam.
Maybe it's that lump of granite in Cornwall. Like, who knows? It's all starting to make sense now.
Oh, dear, indeed.
Yeah, I'm just hoping for a bit of Incredible Hulk-like strength from some radiation somewhere, but I don't think it's going to happen. That's super helpful, Shaheel. Now, for some scans as well, people need to be injected. You talked about the sort of the harmless radioactive sugar. People worry that they might feel sick or be allergic to these agents, but as a general rule, they're very safe.
Generally, they are. Before a patient has a scan, they would have blood tests to check their kidney function, which of course may be particularly relevant in patients who have myeloma, but also to check if they've got allergies. But broadly speaking, for the types of scans for myeloma patients in particular, they would have a CT scan usually without an injection of contrast. MRI scans are often done without contrast in the context of myeloma. And as I say, with PET-CTs, they would have this sugar that they would naturally have with this small radioactive component that is expelled from the body quickly and decays quickly, so is ultimately safe to the patient and the people around them.
This is a bit cheeky, so it comes with a warning. But so I let's say I'm having a scan tomorrow, Monday morning. Life's good. I've got my scan. Why do I have to wait 2 to 3 weeks to figure out what that scan shows? Can we not someone just not have a look at it and let me know straight away? Yeah, sometimes it's quite hard to explain that. Well, we'll see you in like 3 or 4 weeks' time after the scan, because by then X, Y, and Z would have happened. What's going on there with that process?
Yes. If you did have a scan tomorrow morning, I would report it immediately and you would get the results back. And we try our best. I think the reality and practical considerations of the volume of patients having scans, not just in myeloma, but across the entire hospital in all the various specialties and disciplines they may sort of funnel through the radiology department, and then the limited number of radiologists to report. So we do our best to report in a timely way that prioritizes those patients who are most in need as quickly as possible. But yes, it is unfortunately can be a little bit of a delay.
Well, just to come back to that then and sort of regain some ground there in terms of flattery. I mean, I think it is really important to say that what you guys do is different from sending a blood sample into a lab. That's a highly skilled process, but it's totally objective. You get a number from your blood result and that can then be interpreted by the doctor looking after you. Whereas you guys are trained doctors who then super specialise in this field. And so not only are you looking at images, but you're assimilating or you're pulling in all your knowledge of medicine to then interpret those pictures to come up with an answer, which is hopefully helpful for us all. So that's also perhaps why it's just a more complex process, isn't it? There's an awful lot to understand.
Absolutely, because of course the patients who have myeloma or any disease process may have other conditions such as problems with their lungs, their heart, any other organs, and of course may have other health conditions, and all of these conditions sort of interconnect and have an interplay that requires interpretation. And as you say, like the imaging part is just one component to assessment of the patient themselves, as well as their blood tests and making a measured, calibrated decision within the multidisciplinary meeting.
Thank you very much, Shaheel, for that context. And the information that we get reports. So a scan gets a report, and it's a couple of paragraphs of information and a conclusion, which is written for the doctors rather than for the patients in sort of plain English, as we would say. And this information is becoming more available. So patients may see their reports potentially sometimes now before a doctor has had a chance to discuss it with them.
So the reports that we write can be highly technical, and they are written as a doctor-to-doctor communication principally. They will contain specific measurements and terminology that wouldn't necessarily be used by patients or even when you speak to patients in the clinic. With that said, the patients now can access their reports at a very early stage, especially through the NHS app. And so I think to any patients who are listening, the reports can read like complex jargon and can be quite alarming, but to take those reports to really work through them with the haematologist or the doctors looking after you, or even to speak perhaps to the specialist nurses who are part of your care to help direct any queries that they might have. I think that there is a move in some ways to try and frame the conclusion into a way that is more digestible for patients. But I think the principal aim for myself as a sort of medical specialist in imaging is to provide yourselves and the team looking after the patient with all the technical information that we can provide.
We know how terribly busy you are. All these advances have happened in every field of medicine, but we are absolutely delighted, Shaheel, that you and your colleagues exist to help us and our patients shift the dial in the right direction to improve better outcomes. It's remarkable what you guys do. And thank you. You are a scarce but very precious resource.
Thank you. And we all have a great sense of privilege to be able to contribute to patients' care and do our best to make sure that they are treated in a timely way. And to be able to work with yourselves is a real privilege as well. So thank you.
Thank you so much for joining us, Shaheel. It's been a really brilliant discussion, really enlightening. I've learned a lot, and I hope it will provide a great resource for our patients, just understanding a bit more about what sort of scans they can have and when they have them and why we do them.
Any questions for anyone listening, please come in and we can forward them on to Shaheel. I'm sure he'd be delighted to squeeze that into his day. So please do get in touch.
Of course. Thank you so much for having me on. I'm a fan of your pod and I wish you every success. And I hope I've now become a friend of your pod.
Indeed. Will you get a mug? Every guest that comes on gets a mug.
Blue Peter badge or something as well. You never know. We might come up with something else, or a hat, a cap.
A badge and a mug. There we go. And just for those of you who can't see that, Shaheel's just shown us a keep calm and trust the radiologist, which is what we do every day of the week. Thank you very much, Shaheel. Thank you, Sal. This has been the Myeloma Minutes, and we'll see you all at the next one.
Bye. Farewell.
This has been the Myeloma Minutes. We hope that you found today's pod engaging, interesting, and above all, useful and understandable. Please remember that this does not constitute medical advice. Thank you so much for listening. Please do feedback on what you've enjoyed and what you'd like more of. You can email us at themyelomaminutes@gmail.com, and we'll see you at the next one. Bye.